Hiya, it's Caroline here from Pelvic and Core Physiotherapy, and I just wanted to pop on to talk about maple for a moment, but just to really sort of show the differences in how we can treat patients. I've got this is a bipolar probe here, so these are the ones that we commonly find and also ask patients to use at home. So I wanted to explain the difference between this sort of bipolar probe and maple that has this unipolar, has a lot more 24 in fact electrodes on it, and why we can get benefits by using this probe as opposed to this one. So if we had a patient come into our clinic who had some pelvic pain, say, and we did our digital examination, and we found that the pelvic pain, they were complaining maybe pelvic pain on the left hand side, and when we did our examination we found that there was some overactivity on that side, then we can do some techniques to reduce that activity, certainly. But really we wouldn't want to use a bipolar probe to do any neuromuscular electrical stim to that pelvic floor, because obviously we're just going to increase the activity on that left hand side and probably make the patient a little bit more uncomfortable. So these are your slightly more complex type of pelvic floors that we come across in pelvic health. So the benefits of our maple in that situation, and I'm going to show you some images in a minute, is that we can down train one side of the pelvic floor, and we can increase the activity on the other side of the pelvic floor in one session really safely by switching off certain areas. Or it might be that we've got a patient that has very little contraction at the entrance of the vagina, but deep inside the pelvic floor they've got quite a lot of pain and discomfort or overactivity going on inside, and again we can switch off certain parts of the probe so that we're not affecting those bits and making them even more overactive and making our patients even more uncomfortable. So we can get a faster response really to our treatments by treating overactivity and underactivity all in one session, but really safely by only using certain parts of the probe. So I'm going to demonstrate this with now I'm going to put it on a bit of an angle because then you can see it better. Now I've actually put the colour on here, which actually shows this is my pelvic floor, just in case anyone's interested, so you can see it's not growing. So yeah, this is actually why I bought my maple, because I knew my pelvic floor wasn't great. So yeah, some people when they get to their late 40s go a bit bonkers and buy a new car, but I bought a maple. So and I love it, absolutely love it in my clinic, and I wouldn't be without it now, certainly. But this was when I first used my maple, and interestingly I had quite a nasty episiotomy, and you can see that's on the right side. So I've put it on the colour because it's a little bit easier for you to see what's going on. This actually compares my pelvic floor to 100 other women's pelvic floors, but we don't really know what's wrong with those 100 other women. If there is anything wrong with those other 100 women, we don't know. So if we wanted to look at just my pelvic floor, we could put it on this black and grey, white type image. So the darker it is, the more activity we've got, and the lighter it is, the less activity. But I think just for the sake of this, we'll put it here because you can see it a little bit clearer in the images. So what we can see here, these are during my maximum voluntary contractions, so 10 of them, and this is the average. We can look at each one individually, but this is just the average for those 10. And it's showing that I've got very little activity on the right-hand side, but lots of overactivity going on the left. And that is a picture that I tend to see in clinic when patients are coming through and maybe they've had an episiotomy that has obviously gone onto that right hand side, and it just takes the muscles out over there. So I actually don't get any pain in my pelvic floor, but certainly if I had a patient that came in and was complaining of pain, then what I don't want to do is make this side more active, because it's just going to make my client more uncomfortable. So I would switch it off, and I would generally always do my I would want to get more activity going in a pelvic floor. Then I would come back and reassess after I'd done that, and then I would maybe do a little bit of sort of down training on the side that was more uncomfortable. So that would be how I would do it. I'm not sure. Put it in the comments if you do it any differently for those other clinicians out there that have a maple. But certainly for me, I wanted to make this side more active. So then I can put it on a setting, turn off that whole left hand side, and just activate the right side of the pelvic floor. relook and see where am I at, and then I could do some down training on the left hand side if I felt that I needed to, and that's how I would treat my patient all in one session. So you can see, and it might well be that they've got their own bipolar device at home. They might have something that they can use at home, and we'd either look at, down training, everything to get rid of the discomfort. We definitely want to get rid of that first. We might look at some nice sort of hip opener type, relaxed breathing type of things to also down train the pelvic floor. But certainly when they're in clinic, we want to be working on getting this side firing up. And certainly what I've found with my pelvic floor is that just by getting this side to fire off better and work more effectively, it's actually calmed down what's going on this side anyway. So because I was never in any discomfort, I've never done any down training with my pelvic floor. I haven't felt that I've needed to. But that's why we need to treat everybody. We need to treat everyone's symptoms. We need to look at the symptoms that the patient's got and then treat them accordingly. The other thing that's important to note that I've not shown you, this shows sort of most of the overactivity is on that sort of the middle rings, so rings 3 and 4. And what we know from MRI, it's quite accurate, the probe. So when the probe is in vaginally, rings 3 and 4, which are these two in the middle here, so going right the way around, that sort of middle section, are actually sitting on the puborectalis muscles. So right where our episiotomy would be, on that right hand side coming through the puborectalis muscle group there. So it gives us a really, really good picture of what muscle is affected. And as I say, that's through MRI studies that have been done using the Maple. How to treat those muscles, listening to our clients and finding out what it is that they need treated. So as I say, with somebody like me, we would just up train and really get that right hand side working, but not worry too much about the left side. It's highly likely it will dampen down with time, no pain or discomfort. If we had someone that had pain or discomfort, we might want to up train on the right and down train on the left just to get them a lot more comfortable. But we can do that all in one session and then come back, reassess and see what we're looking at. So I hope that's been helpful to anyone that's thinking about getting a Maple. Certainly do feel free to ask any questions, because I love talking about Maple. I certainly love working with it, and it's been an absolute bonus having it in my clinic. It's really helping my patients. They can visualize it, so it's great biofeedback for them as well. So hope you have a lovely day, and talk to you soon. Bye bye.